Okay. Does it pop up okay, Mike?
Looks good to me.
Okay. As Mike said, thank everyone. I want to thank everyone for joining us this morning to briefly cover really what a lot of employers are facing today is confusion, application solutions, penalties, news in the marketplace, different blogs out in the marketplace, etc. Over the past really 3 to 6 months, but most important, the last week to 10 days. So my goal today is to go through the presentation, show everybody our creativity and what we're doing and our success in working through INA and their partnership, as well as have time at the end for a few questions as well. With that being said, what we're going to hit through today, kind of just a little bit about KBA again, ACA reminder of kind of what are all these penalties, compliance, etc. Review of definitions that are out there in the marketplace today, and then solutions that we would say to show any employer in the marketplace a way to get compliant at little to no cost. From an overview on key benefit administrators, we've been around since 1979. We are headquartered out of Indianapolis, Indiana. We're one of the largest independent third-party administrators in the country. We now have close to 550 employees between our Indianapolis headquarters, as well as we've got 60,000 square feet and a couple hundred employees in Fort Mill, South Carolina. With that being said, we've got a little over 1.5 million members under management. Our core, we do the backroom shop for 11 different insurance companies when it comes to fulfillment, customer service, product, etc., with naming Companion, Fidelity, Kemper, as well as Transamerica on a lot of their limited medical business and some of their other hospital indemnity side of things. In regards to our core principles, as what we would say is what differentiates us as a third-party administrator, is one is that its service is one, two is its risk management, three is creativity, and four is flexibility. So there's a lot of different things in the marketplace out there, but I think we stand behind those four things. It's also why we also do the backroom shop for 31 other third-party administrators in the country, and from a risk management, data management side of things. The core principles that we bring in our self-funded traditional business that we do every day, where we, clients as small as 10 lives, as large as close to 50,000 lives, it goes back to the risk management principles, and all those core principles go into this ACA product that we're going to talk about here shortly. From a legal compliance side, again, Wally Gray is one of the top ERISA attorneys in the country. I've been on our staff for a little over 15 years, works in conjunction with the folks at Austin and Byrd and others in different roundtables as well as speaking tours. But when it comes to ERISA, employer law, when we talk about putting plans out to be compliant, looking at it from not just the inside side of things, but looking at outside counsel on everything we do also. From products and services, I wouldn't be here to not be at least tell you, from the true value of what we bring. As you can see here, from TPA Solutions, Small Group, Key Solution, HRA Flex, everything we do is in-house. So we're not outsourcing any of that. So let's talk about ACA for a little bit and talk about a few of the penalties that stick out. One is the individual penalty, the individual mandate. In 2014, it was $95 or 1% of modified adjustable household income, whichever is greater. We're going to see that first come into play when taxes are filed coming up here in 2015 for the 2014 year. So people say, well, a lot of these folks don't file taxes today, and we would beg to differ because a lot of these folks are filing taxes because they are receiving earned income credits. In 2015 and 16, as you can see, it goes up from $325 to $695, 2 to 2.5% of adjusted household income, whichever is greater. So it's starting to bear its fruits a little bit into folks understanding kind of what they have and what the expectation is there as well. From an employer side, what are the employer penalties out there? One is an employer that employs 100 or more full-time employees can prevent being taxed a $2,000 penalty by only offering what's considered minimum essential coverage. And I'm going to hit on that here in a second as well. So that's the first tax. That's a $2,000 penalty. The other penalty is that if an employer doesn't have a plan that has a 60% actuarial value plan, as well as makes it affordable, meaning no more than 9.5% of W-2 Box 1 income, or safe harbor route, that any employee could go to the exchange, receive a subsidy, and at that time, only at that time, is the employer penalized for a $3,000 tax that is actually not tax deductible. So again, those are the two penalties we're going to address here today. The other thing is, when do I need to, with all these penalties, when do I need to comply? Well, 100 plus, we know we have to comply 1/1 of 15. 50 to 99 is 1/1/16 based upon transition. That's out there. A lot of folks many times have said, I have until my next renewal in 15. Isn't that correct? Well, yes and no. Depends on, the transitional rules did not go away in the fact of, if you dive deep into the law that was put out there, is a lot of these times in these industries that we go after, such as hospitality, nursing homes, staffing companies, etc., that we have, typically what you see in there is, I've got a management carve-out in place, I've never offered these folks any benefits before, or I've got way low participation. So we still go back to the fact of transitional relief of, did I offer a qualifying plan in place on 12/27/2012 without a change in my effective date, and did I offer it out to majority of the people? And a lot of times in those industries that I talked about, that's not the case. So actually they have to be compliant January 1 of 15. They don't have until their next renewal. So again, I would encourage you to check with any kind of counsel to verify that, as that's been a changing and kind of circling thing out there. The other thing is that, can I maintain a management carve-out? So 105H discrimination rules have always, it's what are deemed by the IRS that have always been part of self-funded plans. So you could not discriminate and say, this group over here, I'm offering this great plan, and this group over here, I'm offering this lower plan. There's a test that has to be applicable. However, when the law came out, when the ACA law came out, the 105H discrimination rules were introduced into the fully insured side. However, those rules, the final regs, the final rulings, were supposed to come out this year in the spring. They were then supposed to come out in July. They've been pushed back until next year. At that time is when the final regs from outside counsel that we have says at that time they will be released, and most likely the employer will have until their 2016 renewal to be compliant. So the idea of a management carve-out still being in place. Now, it's all throughout the country. Each carrier has their different opinion on management carve-outs, but there are a lot of them still being written and maintained throughout. So a couple of things when we talked about those two penalties. I want to address the first one right away. The first one is minimum essential coverage. Minimum essential coverage is what is deemed, when the law was written, that, and it gets confused a little bit with essential health benefits. Essential health benefits are the 10 benefits that have to be out there as guided by the government for under 50 lives, as well as on a fully insured basis, that include hospitalization, RX lab, things such as that. What also said in that law is that if you are a self-funded plan, the only thing you must have is minimum essential coverage. So by having minimum essential coverage, which is 100% of the 63 preventive services as listed by the CMS, which I'll show here in a second, if you offer that, the employer, and I say offer it, the employer gets out of their $2,000 penalty. When we show a proposal, we show it three ways. We show a voluntary rate, we show a 25% employer contribution on the single, and a 50% contribution on the single as well. So three different ways to fulfill the promise, as well as the only thing the employer has to do is offer it. Now, our participation requirement is I have to have 10 employees take it, no matter any offering, whether it's voluntary, 25 or 50%. As long as we hit 10 people taking it, we satisfy and have a group plan there. On the employee side, the employee that purchases this gets out of their individual mandate. So back to the previous slides where we showed 1% in 2014, 2% in 15, and 2.5% in 16. Again, it's going to start to add up. On average, these minimum essential coverage plans cost about $55 to $65 on a maximum liability basis. And again, it's self-funded, so there's definitely ways to recoup dollars on the surplus side. Those preventive services, as defined, with the government, with CMS. There are 15 covered services for adults, and let me make sure I make it clear as well, is that the preventive services are what they are. If somebody goes in for a preventive service checkup and all of a sudden a diagnosis is attached, it's no longer covered. It's preventive services only. 22 for pregnant women as well as women, as well as 26 for children. So a total of 63 preventive services that have to be in the plan from a minimum essential coverage side to be offered and paid at 100% in order to avoid the $2,000 penalty as well as to avoid the individual mandate. Now the second part of this is the minimum value plan. What the government says is that in order to avoid the $3,000 penalty, you must have a plan that is at least a 60% actuarial value plan, one, and two is that I have to make it affordable, meaning the employer can't charge the employee any more than 9.5% of W-2 Box 1 income, or what's considered safe harbor route, which is taking the lowest average wage in the employer, taking 9.5% of that number, and charging that across the board. So now, what do I do and what options are out there for us? From our side of things, we have a program that we've rolled out in the marketplace for the last 18 months, which is called Key Solution. And truly, it's the ability to be ACA compliant at little to no cost for the employer. And it gets into beyond just peddling a product, but it talks about solutions, it talks about reporting and planning, and it also talks about on the tax planning side, and I'll hit on all three. In particular, what industries are we targeting with this plan? Right here, the restaurants, the staffing companies, the nursing homes, the home health care, hotels, resorts, casinos, security companies, convenience stores, oil and gas. And from this side of things, we rolled out our new minimum value plan on 8/1, and if I look at 8/1 sales, 9/1 sales, 10/1 sales, and look at already what's been sold for 1/1, there's over 500 cases already in the hopper that are being sold on this plan. And that's from employers as high as 100,000 employees down to employers at 100 lives, because it truly is a solution for them that gets at the needs for the employer at the most effective price. Some of the highlights with this program. First of all, it meets the guidelines at a 60.1%. It's going to help the employer avoid all penalties for ACA at little to no cost. One of the end slides here, as I will show, from the tax side of things, truly how the employer, getting to $11 employee per month. Benefits that are easy to understand and explain to all employees, and truly the ability to bring more benefits and more value to more people. From the risk management side of things, we integrate our 25 chronic conditions, which we have a patent on that we awarded in 2010. So the idea of somebody copying what we're doing on the chronic conditions and really reaching out like we do in our core major medical plan, it's not possible. We have 28 nurses on our staff that are reaching out to the members that I'll show here in a second. But that's for the folks that have never had insurance before, which is a lot of times in this situation, they need to have the nurses at their side managing, getting them into the doctor exactly as what we do on our traditional major medical side. Because at the end of the year, after the plan's in place for a year, now we want to look at the data. We want to turn data into intelligence and talk about what we can do to stabilize costs for years 2 and 3. We integrate all of our administration functions for easy administration, integrated stop-loss policy. So I said the plan is a self-funded plan. Companion Life is the the risk taker on the product, which is Blue Cross, the second largest Blue Cross Blue Shield affiliate based out of Columbia, South Carolina, an A+ rated company. Also in California, New York, Connecticut, New Jersey, we're using Gerber paper. So again, each of the states we do have covered. Consolidated billing, eligibility for all benefit plans, and truly a single 800 number to call no matter which product we offer, whether it's our core MVP or some of the buy-ups where we integrate some other carriers into it, they're still calling the same number because we're the administrator behind all of it. Now, when we look at the MVP plan, it's a zero deductible $1,850 out-of-pocket plan. There's going to be copays for office visit, ER, lab, and X-ray, as well as RX. There's $10,000 of life and AD&D. We're going to have the MEC benefits. They have to be in there. Minimum essential coverage has to be in there to be a qualified plan, as well as our chronic disease management benefit as well. When we look at these plans, there's a couple things that stick out, because what the government says out there, when we talk about plan designs that we have out there, that what you see here is what is covered, where you wouldn't see hospitalization covered. A lot of people would freak out and say, what do you mean we can't have that covered? How's it hitting 60.1%? What are you seeing? Here's what we're seeing with our enrollment so far, is that if you talk to the average person with those industries where they're making $8 to $10 to $12 an hour, and you can show them a plan that has first dollar coverage, 100% coverage for 85% of the things they use every day, this plan is right for them. When you look at it, if somebody is sick, is this plan the right plan for them? Absolutely not. If they ought to go to the exchange, I understand they don't get a subsidy, go to the exchange and buy a plan there. This plan is not right for everybody. This plan, equivalent to a traditional major medical plan, is apples and oranges, and I'm not trying to oversell it. What we're trying to say is that a plan that gets an employer compliant, that must meet the demands of ACA today in a quick time frame here, this is absolutely the right plan. If you look at somebody who makes $8 to $10 to $12 an hour, again, and they're presented in some of the illustrations as well as some of the offerings that are out there, which is a $6,000 deductible plan, a bronze level plan, which in 2015 goes to a $6,600 deductible plan. Somebody making $8, $10, $12 an hour, that plan's like not having insurance or hospitalization anyways, because they can't afford the deductible. They can't afford the $4,000 or $5,000 deductible because that's 25% to 30% of their income. What we're seeing is we've had tremendous success on the participation in these plans, about 15 or 20 points higher than we expected. And it goes down to the idea of truly what is affordable to somebody that makes $8 to $10 to $12 an hour. Again, trying to make a difference here, but also not trying to say this plan, is this a plan that's going to replace a major medical plan? Absolutely not. Again, unless somebody's dire desperate need, that we're just completely shutting things down. That could be an option there. On average, the MVP cost about $200 on average, all in max liability. When we talked about the chronic disease management, what I wanted to show you all here is just what are the 25 chronic conditions that we're managing with those 28 nurses. And what the American Medical Association would say is that somebody that has, on the right side here, is that here are the minimum levels of care. So for example, an asthmatic, they're supposed to have 2 doctor offices per year and 1 spirometry, which is where they go in and blow into a tube. All we're saying is that these minimum, we're not trying to play doctor. If they have more than that, great. But these minimum levels of care on this right-hand side here, these will be paid at 100%, no copay, no deductible, no out-of-pocket. We want to get people into the doctor at all possible to get seen for issues that they have, to get programs established. Again, this goes back to the risk management side. At the end of the day, at the end of the year, being that it's a self-funded plan and you have data for your client, you now can make judgments as well as plan designs for years 2 and 3 versus many times in a fully insured world where you have no data. You will have data to make designs, and that's one of the things that differentiate us. This is what we always talk about. We have to be able to turn data into intelligence and make it actionable. If you have a report to have a report, it does nobody any good. Show me a report that has some meaningful data that I can show my employer to actually make plan changes that are with data that's affecting my group today. From a underwriting and funding side, there is no underwriting that's guarantee issue. They must be W-2 employees. I can go down as low as a 15-hour employee. My only participation requirement is I must have at least 20 employees or 10% enroll, whichever is greater. So again, 20 employees or 10% enroll, whichever is greater. The contract's a 12-18 contract, and now let's get into the self-funding part. All of a sudden, people get nervous about self-funding. Well, wait a second. I've never been self-funded. There's risk associated with it. But remember, like I said, hospitalization not being covered, which is one of the largest components of a major medical plan, is not covered. Therefore, the risk is not there, so there is no specific stop-loss needed. However, there's aggregate coverage. That's where companion comes in, as well as what's called aggregate accommodation built in. That's going to give a monthly cap. So let me make it simple here, is that if my annual cost were $120,000, that's the most the client would pay, is what we show it on the contract. The aggregate accommodation tells them that they're going to pay $10,000, assuming the same enrollment, they would pay $10,000 a month not to exceed the $120,000. Now, the other part of this is it being a 12/18 contract. The first number, if I drew a line, and I went January 1 to December 31, that is the 12 months of the policy in force. So claims are going to be incurred in those 12 months. And what we're saying is if I drew another line underneath that started from the same starting point from January to December 31 and then take it out 6 months more, is that's what's considered run out. So if this didn't work out for the client after 1 year, we're also going to pay claims for additional 6 months after termination. That is automatically built in. There's not a separate terminal liability fee. Another fear with self-funding. What happens at the end? Can I get out of the program? What am I trapped into? We've tried to put every approach here to make sure the client is, and as well as you, are in the most comfortable position to make the recommendation here. Now, from a funding side, the employer has two choices. They can fund this just like fully insured or level funded, write a check every month, $10,000. They're going to get a statement that's going to say, here were your minimum cost, here were your actual claims, and here's your surplus. At the end of 12 months, there's a risk wrap document that allows them to take that surplus and use it to offset other employee benefit expenses. Only if the employer was paying 100% of it could they take that money and put it back into their pocket. If they're not paying 100%, it has to be used for other employee benefit expenses. The other method is that if a larger case or somebody that's comfortable with it can fund it on an ASO basis, where they're paying the minimum cost plus claims transferred on a weekly basis not to exceed their monthly cap, and therefore they hold on to their own reserves. So again, we're not trying to pigeonhole a client into you have to do it this way. We're trying to bring flexibility and choice in everything we do throughout our programs. The last couple parts here is to look at as an example. And the assumption I'm going to make here, because now we're going to get in the tax planning side of things. The assumption here is that the average salary is $15,000. If I look at 9.5% of $15,000, because that's the most the government said if I went on this method of taking from a W-2 Box 1 income, that I could collect is $119 a month. As I said, on average, our MVP costs $200, higher or lower depending on where you are in the country. We also have to look at this is a gray area. The tax considerations, 20 to 35% tax bracket, or 40%, the FICA, the payroll taxes, etc. The bottom line that we want to show next is the ability to get an employer ACA compliant at little to no cost. So if I look at my average cost of $200, my employee contribution is $119, that leaves me $81 left over. Now, with these plans, we expect a surplus that will be generated. So if we look at the build cost minus the fixed cost, we're going to be at $38 from a surplus that's generated. Now, the other thing, which is the gray area, is the corporate tax rate. If I look at this employer in this example here, this is showing an example of a 40% corporate tax rate that can only be used on the employer contribution. So $81 times the 40% generates a write-off of $32. As a CFO would say, this Heath, I've got to spend the money in order to write it off. I get that, but you're going to have to spend the money to be compliant. At the end of the day, if I take my $38, my $32 off my $81, my true employer cost is $11 PEPM based on an average salary of $15,000 in a group and using the 9.5% contribution. One way to look at it. That is a game changer in this marketplace. Secondly, how do we all get paid? We get paid based upon enrollment. So if I looked at the same example and I drew this line straight down, if the employer told me, Heath, I can afford 50 or 60 bucks, then if I use the same example here, and if I said, if this number here was $200, and I'm going to charge the employee $60, so that leaves me $140 left over. My surplus that would be expected, and now I'm taking the $140 times the 40% to generate my corporate tax rate right off, and I add those two together, subtract it off my cost, and I'm at $52. I hit the target, as well as from the employee side, I've been able to generate where if I divide it into a weekly basis, I'm at $11 to $12 a week. That's something people will buy. This example here is something that, getting with your INA rep of really diving into details about what is different about this product. Why do we put this solution in place today? A couple things. One is it allows the employer to be in compliance with ACA at little to no cost. It creates an employer strategy which enables employees who do not have coverage today to purchase a low-cost plan with meaningful benefits and satisfy their individual mandate. It affords the ability for the employer to participate in a surplus. Big thing here is it allows an employer to begin gathering data and turning data into intelligence, because you need to strategize versus just plugging a hole and filling in for, just to have a product to get somebody compliant. That's great, but if I'm an employer, I'm going to ask the second question, okay, what do I do in year 2 and year 3? I don't have that crystal ball, but if all of a sudden I have data, and for example, we're talking about the minimum levels of care with those chronic conditions. If somebody has a chronic condition, you can set rates based upon compliance and non-compliance. It's what the government and what the law allows us to do. Ideas like that we do in our traditional major medical side being built into a product such as this with data. And at the end of the day, it allows employees to feel they've been given the best opportunity that's most affordable to them and their families. From our side, we truly look at the employer and employee experience. We provide all the necessary documents for both the employers and employees. A welcome packet will be provided to each employer, outlining the benefits and making sure they understand the plan. It truly is a turnkey package. COBRA administration, notices, SBCs, having online enrollment, things such as that are built into our product. Individual packets sent to each employee's home, provide the guidelines, the certs, etc. Employees having a full-service customer support team once they're enrolled that answers all the questions regarding claims, eligibilities, or any other benefits that are associated with this program. At the end of the day today, our job that we're championed by our employers, consultants, brokers is to have the most effective way, flexible program in the marketplace to help employers survive the challenges with ACA.
Thank you, Heath. That's a lot of information to take in. One of the things that I wanted to kind of tee up here for you, Heath, is that one of the things that we're seeing if you're checking your news articles, there's a lot of talk about these skinny plans. There's talk about are these truly a legal plan? And I know that you guys have done a lot of research on this. With that teed up, can you kind of give us an idea of what that is and hit the ball down the fairway for me?
Sure. A couple things in. Again, the information being supplied to the INA reps there that can work and support with you after some non-disclosure agreements are done to give them the true details and the legal side behind it. But the bottom line is this, is that there's been a lot of different press articles out there, and I'll start in the past month. There was an article out there pushed out from Turnian. Turnian talked about, as well as UBA put out an article last Friday that talked about the 4 core benefits being part of the MVP calculations. With the research that probably wasn't done fully is that there were proposed regulations that went out in 2013 that included the 4 core benefits. The final regs that went out they eliminated the 4 core benefits. So the folks that have done and put into that, they didn't understand the full research, and we've provided INA the actual copy of the proposed regulations versus the final regulations, where you can see for yourself exactly for each of our employers that have asked about it. That's the first one. The second one was an article that was out there from the Kaiser Foundation, as well as went out to the Washington Post. What's interesting about that is the first speaker in there that was mentioned was Liz Smith, who is actually the practice leader for Assurance, that is a consulting house out of Chicago. She called me before that article went out, said things have been twisted here a little bit, just to let you and Larry know. They're in the midst of enrolling 103 cases with us today, which make up well over 150,000 employees. Lockton, which was mentioned in there as well, they're in the process of enrolling well over 8 cases over 5,000 lives. So from those side of things, some of those articles that get put out, there was also a rebuttal to that article the following week that absolutely from the 2 different consultants saying the actual law. There was also, again, just trying to give everybody full details of what I know, there was also an article that was published from SPBA out of Washington that from actually the person that created the rater that said HHS was fully aware of these plans. It was what was put out. If you look at the actuarial tables, which was done by the Actuarial Society of America, if anybody's an actuary, they know what accrual tables are. They're in tab 2 and 3 of the rater. It shows all the data as to what they did to make up the rater. Again, that's right from the person that created the rater, saying people fully aware of it. Now the latest one, scuttlebutt, is from last week from a meeting that Ed Lenz put out, and everybody took that verbatim. Again, Ed called me. He represents the American Staffing Association from council there, and leaked stuff that the Treasury Department is considering making a change to the MVP plan that you have to include hospitalization. There's a couple things and facts about that, and that's been scuttlebutt a little bit for the last couple months. And that's where the article is from. The actual person that created the rater put that out there, that it was done on purpose. That's how it was created. HHOS was fully aware of it. This rater's been out in the public domain for 2.5 years. Anybody's had chances to make any changes they wanted in the last 2.5 years. And just because we're 11 weeks away from the employer having to be compliant, that we're looking to make changes because of creativity done within the plan designs. Second part is this, is the IRS would say is that the struggle that they're having in Washington is that no matter what, it's law. It's how the law was written. It goes back to the days when we first rolled out minimum essential coverage. When minimum essential coverage was first rolled out 18 months ago, the whole push was watch out for that loophole, etc. They're going to close the loophole. Well, the reason why the loophole wasn't closed is because the law was written how it was written. So from that side of things, taking that into consideration, and also published in that same article last week, was that the government has no problem with MEC plans, minimum essential coverage plans, which is just preventive services only. Doesn't make sense on flipping that side of things. The other part of that article talks about no decisions will be made until after midterm elections. Well, midterm elections, you're talking about employers that are 100,000, 50, 60, 10,000 lives that are enrolling right now today through their different open enrollment periods. They would find out after November and then have to make a change. Again, what has been the past performance is that there's been grandfathering and transitional relief that's been there. But the point here is that these are articles, these are rumors. There's nothing signed out there. There's nothing proposed. There is no regulation that says this is changed or that's changed. However, if anything goes into effect and makes a change, key benefit administrators are ready with backup plans to adjust and comply with any possible and all changes that would be made in these plans. We're too far down the road and heavily invested with this program to make sure we make it work for our brokers, consultants, and employers. I know it's a long-winded answer, Mike, but that's kind of giving you history as well as the latest as to what we're dealing with.
Perfect. No, I think that's perfect, and I appreciate it. I'm going to flip back over to myself here, Heath, take the controls away from you.
Okay.
And just want to let all of you that are out there, if you have any questions, feel free to get in touch with your INA sales rep. Additionally, if you were interested in it, we have developed a nice piece, Key actually developed this piece for us that talks about the tax penalties under the ACA. And it's a 2-sheet flyer that can be customized for you to hand to your large clients. And what this does is just breaks out what are the actual penalties for employers that they have to be aware of, as well as the employees. It shows you the MEC, tells you what the penalty is, but also tells you what MEC covers. Same thing with MVP. And then gives you a little bit what are the differences in the key solution. And there are several. I will tell you that INA, we have companies that offer the MVP style plans. This is certainly the most comprehensive of any of the plans that we have out there today, and far and away the whole idea of them reaching out to clients and helping the insurers and helping them with their chronic disease management is just huge in this arena. So once Bob, you can see this has actually been customized to me. We can customize this to you. So if you have interest, give us a call here at INA, 800-456-7999, and we'll get you hooked up with somebody and we can get that to you. I want to thank you for this. If you have questions, send them in to us. We will answer those questions as they come up. Once again, wanted to thank everybody for this morning. This will be recorded, and it will be put out on the INA website probably within a day. So if you want to see this again and you missed it, or you just want to go through it again, it'll be there for you. Well, we thank you. Thank you again, Heath, and make it a great day and good selling.
Thank you, Mike.